Hello everyone, welcome to Easy Medicine. Today we have a 58-year-old male farmer by name Ramesh. He presents with a 4-week history of high-grade fever with chills, fatigue, weight loss, and night sweats. He is also found to have a new holosystolic murmur along with splinter hemorrhages in the nail beds and purplish lesions in the fingertips. So what is the possible diagnosis in this patient? And how do you evaluate him? How are you going to treat him? And what are the possible complications that may arise in this patient? The possible diagnosis here, based upon the clinical presentation, is infective endocarditis. And by the end of this video, you will be able to answer all the questions that have been put out here. We'll discuss this topic in this brief outline, starting with the definition, pathophysiology, risk factors, etiology, clinical features, diagnosis, management, and prevention. Right? Let's start with the definition. The infective endocarditis is infection of the endocardium involving different structures of the heart. They are native valves or the prosthetic valves, low pressure side of ventricular septal defect, or intracardiac devices. Now let's look at the pathophysiology of infective endocarditis. So when there is a primary cardiac structural abnormality that is resulting in a non-laminar flow, when there is a non-laminar flow or a turbulent flow of blood inside the heart, the endothelial damage happens. The endothelium, when it is disrupted, that results in the formation of a platelet fibrin thrombus. Right? This platelet fibrin thrombus, when it is forming over a valve, you call it as a vegetation. At this stage, this is called as non-bacterial thrombotic endocarditis. This NBTE can also form in certain diseases like malignancy or chronic diseases like SLE. Right? When this NBTE presence is overlapped or over this NBTE, when the patient gets infected because of some infective source, it could be because of a bacteria or a fungus, then the patient will develop infective endocarditis. So when the patient is having an infective source and when the patient is immunocompromised, together the patient can have infected vegetation. At this stage, the patient is supposed to have infective endocarditis. So this infected vegetation can affect the valves, or the infected vegetation itself can embolize, or against this infected vegetation, our immune system can mount an immune response and the antibodies will bind to that antigen and the antigen antibody complexes may disseminate all throughout the body. So, because of any of these three effects, the patient can develop pathological consequences. So, the effect on the valve could be either a worsened valvular abnormality. The patient may be already having a valvular abnormality because of which there is a non-laminar flow, and that could have resulted in the formation of an infected vegetation. And this infected vegetation will further result in the destruction of the valve, and the valvular abnormality is worsened. There is a possibility of a new regurgitation, and the valvular dehiscence can happen, and there is also a possibility of development of abscess within the valve. Right? So these are all the possibilities with the valve. The dissemination of embolus will result in vascular phenomenon depending upon the occlusion of the arteries. So there can be a macrovascular occlusion or there can also be a microvascular occlusion. The macrovascular occlusion can result in organ infarcts, stroke, or acute coronary syndrome. The microvascular occlusion can be seen in the nail beds as well as at the palms and soles. In the nail beds will result in the buildup of pressure inside the arterioles and the arterioles rupture that will result in splinter hemorrhages. In the palms and soles, there is development of JNV lesions. So these JNV lesions develop because of the septic emboli, and the septic emboli will result in the formation of microabscesses that is visible in the form of hemorrhagic macules, and they are usually painless. So these painless erythematous macules are nothing but the JNV lesions. Now, because of the antigen antibody complexes, there can be development of certain immunological phenomenon that is visible at retinal vessels, kidney, and fingers. At retinal vessels, there is formation of these rod spots. The rod spots are nothing but retinal hemorrhages, and there is a pale center if you can observe, an yellowish or a pale center. The antigen antibody complexes will result in vasculitis or thrombosis in the retinal vessel, and that will result in retinal vessel occlusion. And because of increased pressure, the vessels will rupture and there is hemorrhage at that particular site. Then why is there a pale center? This pale center in the midst of the hemorrhage is because of vasculitis or leukocytes. On the kidney, the effect is glomerulonephritis. And on fingers, the patient can develop oscillar nodes. The oscillar nodes are nothing but these purplish nodules that you can observe on the palms and soles. Why are they appearing? The antigen antibody complexes again will result in vasculitis. The same mechanism happens here as well. The microemboli in arterioles and microabscesses in the dermis, they are visible in the formation of purplish nodules which are quite painful. So Janeway lesions are pain away lesions, and Osler's nodes can be remembered as if someone is screaming, "Oh, it's painful." Osler nodes are painful. Now let's look at the risk factors. So there are cardiac risk factors. A kind of valvular heart disease, highest risk is associated with mitral valve prolapse with mitral regurgitation, more than mitral regurgitation, more than aortic stenosis or aortic regurgitation. Presence of prosthetic valve, cardiac implantable electronic devices, congenital heart disease, hypertrophic cardiomyopathy, Marfan syndrome, non-bacterial thrombotic endocarditis are the cardiac related risk factors. Now, we also have the immunocompromised states of the patient. It could be because of diabetes or infection with HIV. And certain infection sources should also be present for the NBTE to transform into an infected vegetation, right? So, a previous infective endocarditis can be a source. Indwelling central lines for the patient if the patient is staying in an ICU for a longer time, long term hemodialysis, and intravenous drug abuse. The staph aureus is the most common organism in these patients. Genitourinary tract infections can introduce enterococcus into the circulation. Disruption of the gastrointestinal tract can introduce streptococcus bovis into the circulation. And finally, a poor dental hygiene can introduce streptococcus viridans into the circulation. So these are all the infection sources that may be seen in a patient of infective endocarditis. When we talk about the etiological organisms, overall the most common cause of infective endocarditis is Staph aureus, right? So depending upon whether it is a native valve or a prosthetic valve, we have different causes of endocarditis. When it is a native valve endocarditis, the most common cause of acute infective endocarditis is Staphylococcus aureus. The subacute infective endocarditis is caused by Streptococcus viridans, and if the patient is an IV drug abuse, Staph aureus is the most common cause. And in prosthetic valve endocarditis, the duration is important here. After the prosthetic valve replacement happens, within 2 months of the surgery, the coagulase negative staph is more common than the staph aureus. During 2 to 12 months after surgery, still the coagulase negative staph is more common than the staph aureus. And after 12 months, or you can also call it as late prosthetic valve endocarditis, this is similar to that of the native valve endocarditis, where the most common cause is Streptococcus viridans. After that comes the staph aureus, and then the coagulase negative staph, and lastly, enterococci. So broadly speaking, the common causes of infective endocarditis are the staph aureus, coagulase negative staph, Streptococcus viridans, and the enterococci. Cardiac implantable electronic device related endocarditis can be the result from the Staphylococcus aureus or coagulase negative staph. We also have this culture negative endocarditis, where even if we send the blood samples for culture, we won't be able to grow this organism. They are nothing but the Hasek organisms, Coxiella burnetii and Bartonella. So these organisms cannot be cultured by the traditional blood culture methods, and hence they are grouped under the culture negative endocarditis. Let's look at the clinical features. In case of acute infective endocarditis, there is rapid damage to the heart valves that spread to the extracardiac sites because of dissemination, and the patient will have death within weeks. In case of subacute endocarditis, the disease is gradual and the cardiac structural damage is also gradual, and this rarely metastasizes. So when the patient is having right-sided infective endocarditis, the patient will have pulmonary symptoms. Why? Because the blood from the right heart is going to eject into the lungs through the pulmonary aorta, right? So the septic pulmonary emboli are going to be the reason for these pulmonary symptoms. And the patient can also have the right-sided heart failure because the right valvular damage happens there. So when the patient has left-sided infective endocarditis, new onset murmur or worsening of a pre-existing murmur can be seen. And dislodgement of the embolus from the left side of the heart will result in dissemination into the systemic circulation, and the patient can develop stroke or acute coronary syndrome, renal infarcts, splinter hemorrhages, and all these kinds of features. And we also have the common constitutional features like fever with chills, arthralgia, or myalgia. The patient can also have clubbing, splenomegaly, and pallor when you look at the lower palpebral conjunctiva. And evaluation. The first investigation that you should do is a 2D echo. There are two kinds of echocardiography, transthoracic echocardiography and transesophageal echocardiography. The transthoracic echocardiography is 60% sensitive in identification of the vegetation, whereas transesophageal echocardiography is 90% sensitive in identifying the vegetations and the abscess. And while you are doing a 2D echo, firstly do a transthoracic echocardiography. If a vegetation is visible on transthoracic echocardiography, then the diagnosis is confirmed. But if it is not visible, then do a transesophageal echocardiography. If it is positive now, or the vegetation is visible on transesophageal echocardiography, still okay, infective endocarditis is confirmed. Now, if it is still negative, if you are still having the suspicion of infective endocarditis, repeat transesophageal echocardiography after 7 to 10 days, or you can do a CT angiography or PET-CT in the patient. The diagnosis is based on the modified Duke's criteria. This can be simply remembered by using a mnemonic B fiber, BEFIBER. The major criteria are the blood cultures and the echocardiographic evidence. The blood cultures are nothing but two positive blood cultures of typical organisms drawn at least 12 hours apart, or all of three or 3 out of 4 blood cultures should be positive with first and last separated by 1 hour, or a single positive blood culture of Coxiella burnetii or a serology IgG positivity of Coxiella burnetii will also satisfy the criteria of blood culture for this patient. Now, number 2, the echocardiography or CT angiography or PET-CT, basically a radiographic evidence of vegetation or abscess or new dehiscence of the prosthetic valve and a new valvular regurgitation. These two come under the major criteria. Then we have the minor criteria. Minor criteria can be remembered by using a mnemonic fiber. F for fever, a temperature of more than 38 degrees centigrade or 100.4 degrees Fahrenheit. Immunological phenomenon, which we already understood, they are glomerulonephritis, Roth spots, oscular nodes, the presence of rheumatoid factor. B for blood culture positivity or serology positivity not meeting the major criterion. Number 4 are the embolic phenomenon, which are nothing but the JNV lesions, conjunctival hemorrhages, major arterial emboli resulting in acute coronary syndrome, stroke, or intracranial hemorrhage. And lastly, R for risk factor. But how do we come to the diagnosis based on the major and minor criteria? Firstly, one major or two minor criteria are fit for nothing, they are not useful for diagnosis. So, you can call it as possible endocarditis if the patient has one major and one minor criteria or three minor criteria. You can call it as definitive endocarditis when we have one major plus three minor criteria or five minor criteria or two major criteria. Both possible endocarditis and definitive endocarditis should be treated as having infective endocarditis. The treatment would be the same. The sensitivity of Duke's criteria in the diagnosis of infective endocarditis is 80% and specificity is 95 to 100%. Okay, so in addition to all these investigations, if you look at some basic other investigations, when you look at the CBP, the patient will have anemia and leukocytosis, and ESR is elevated, CRP is elevated, and RA factor is also positive, which is also included in the immunological phenomenon in the minor criteria. The mainstay of treatment for infective endocarditis are these antibiotic regimens. Let's formulate the antibiotic regimens. The duration of antibiotics are usually 4 weeks for native valve endocarditis and 6 weeks for prosthetic valve endocarditis, and gentamicin should be used for 2 weeks. So, depending upon the organism, the antibiotic regimens differ. So, starting with the Streptococcus viridans, the first line are the ceftriaxone or amoxicillin or penicillin G for 4 weeks, used at a dose of 12 million units. If the patient has penicillin allergy or resistance, then change to vancomycin. If the patient is only having a partial penicillin resistance or a relative resistance, you can add gentamicin to the existing antibiotics that are ceftriaxone or amoxicillin or penicillin G. And when you are using penicillin G, use 24 million units here. And when to add gentamicin? Gentamicin should be added if you are treating a prostatic valve endocarditis patient or a patient with penicillin resistance, and to reduce the treatment duration to 2 weeks. Actually, a patient of native valve endocarditis should receive 4 weeks of antibiotic treatment, but if you want to reduce the treatment duration to 2 weeks, you can add gentamicin for this patient. Now, second organism, Staphylococcus. We have methicillin sensitive Staph aureus, methicillin resistant Staph aureus, and the coagulase negative Staph. For methicillin sensitive Staph aureus, the treatment of choice would be oxacillin, since this is still methicillin sensitive. But if the patient is having penicillin allergy, give cefazolin, which is a first generation cephalosporin. If the patient has MRSA, the treatment of choice would be to give vancomycin. And if the patient is having cons, that is, if the blood culture is showing the coagulase negative Staph, treat with vancomycin plus gentamicin plus rifampicin. So the question would be when to add gentamicin and rifampicin? It is in the cases of MRSA with prostatic valve endocarditis or coagulase negative Staph aureus patients. Third one, Enterococcus. If the culture shows Enterococcus, start with penicillin G or ampicillin plus gentamicin. If the patient is having penicillin allergy or resistance, then change to vancomycin plus gentamicin. And if the patient is having vancomycin resistance, change to fosfomycin plus gentamicin. See, gentamicin is added at every stage. What if the patient has gentamicin resistance? Then you can give ampicillin plus ceftriaxone. So ampicillin and ceftriaxone together has the synergistic effect. That is why these two drugs are used together when the patient is having gentamicin resistance. And when to add gentamicin? Remember, we should add gentamicin in all the cases unless if the patient is having resistance. Now let's formulate the empiric regimens. We need a regimen for the native valve endocarditis or the late prostatic valve endocarditis, and we need a regimen for early prostatic valve endocarditis. So the treatment regimen for NVE or late PVE requires coverage for staph, strepto as well as enterococci. So the treatment would be vancomycin plus ceftriaxone. If at all required, you may add gentamicin there. But in case of early prostatic valve endocarditis, we should cover staph, strepto, enterococci, and also coagulase negative staph. And coagulase negative staph requires gentamicin plus rifampicin. So the treatment would be vancomycin plus gentamicin plus rifampicin. And for HASEC organisms, the treatment would be ceftriaxone or ampicillin. For Coxiella, Brucella, and Bartonella, the treatment of choice is doxycycline. And for Bartonella species, the doxycycline plus gentamicin is preferred. If the patient is not having an acute infective endocarditis, antibiotics should be deferred till the culture reports are available. Why? If the patient is having acute infective endocarditis, we have already understood that it is quite destructive. There is no time for us to wait. So, start away the patient on the antibiotic regimens, and depending upon the organism and the sensitivity patterns, you can adjust the antibiotic regimens later. But if the patient is a subacute infective endocarditis, there is no urgency to start an antibiotic there. You can wait for the culture reports to come. That is what is the meaning of that last point. The indications for surgery: a large vegetation of more than 10 mm size, a persistent fever or culture positivity after 7 to 10 days of appropriate antibiotic use, or acute heart failure or shock due to valve dysfunction, paravalvular extension in the form of abscess, fistula, or heart block, fungal endocarditis, or multi drug resistant strains, since the antibiotic therapy is ineffective in those patients. And if there is recurrence after optimal antibiotic therapy, and if the patient is having continuing embolization. Now let's talk about the prevention or the antibiotic prophylaxis. When should you give antibiotic prophylaxis? The indications are presence of prosthetic valves, or if the patient is a post cardiac transplant, prior infective endocarditis, and the presence of congenital heart disease, that is at least 6 months post repair, and presence of a cyanotic heart disease, cyanotic congenital heart disease is an indication for antibiotic prophylaxis. Before procedures like tonsillectomy, adenoidectomy, and dental procedures to prevent Streptococcus viridans infections. And the regimens that are usually followed are the amoxicillin or cefazolin or ceftriaxone. You can also use clindamycin. That is all about infective endocarditis. Hope you got all the answers for our questions which we have already put in. Please share, subscribe, and follow my channel.